So, good evening, everyone. Welcome to this new session of the video based topics where I would tell you about some practical tips in ophthalmology. So, these questions would be useful for you not only for your PG entrance exam, it would be also useful for those students who are in their third professional exam and also for those students who are the interns or the optometrist to learn how basically you can basically go ahead with the practical tips in your clinic or during your rounds. So give me a thumbs up if you can appreciate my voice and my slide is visible to all of you. Okay, so with this I would be just starting the session, and the topic that we would discuss today would be the direct ophthalmoscopy and indirect ophthalmoscopy, one of the most important topics in the clinical examination which can be asked in your practical vivas also. I'm your ophthalmology educator, Dr. Vineet Sehgal, and you can follow me on the Unacademy learning app for my free videos and my YouTube channels. On this channel, that is the Let's Crack NEET PG channel. Okay, so how you can see my special classes? You can just download the Unacademy learning app from the iOS store or from the Play Store, where you can go into my profile, that is Dr. Vineet Sehgal, and see it. If you are a PG aspirant and want to basically enroll for a course, you can do it for any FMG student. If you want to basically go for the FMG exam, you can join the target batch for FMG. If you are basically interested for the next 2022, you can enroll for that, or if you want the morning or evening batch, you can enroll as per your requirement. Okay, then we have the plus subscription where you are having the access to the live classes. If you want to see the recorded lectures of the top faculty, you can just go to the iconic subscription where you would have an advantage of Unacademy as well as the prep ladder subscription. How you can get some discount on that? You can get a 10% discount by using my code, that is Opthal10. In any of the course that you want, you can use my code Opthal10 and get a 10% discount. So coming to the topic, we would be discussing today about the direct ophthalmoscopy. Can you see this one, this instrument? This is my direct ophthalmoscope. So if I tell you, this was my first instrument that I purchased with my salary when I got into the post graduation. So my seniors in the RP Center AIIMS, they told me that it is something through which you would not only just learn the clinical skills, it is the something like a stethoscope to an ophthalmologist. So with this one, this direct ophthalmoscope, the most of the skills that I have right now, I learned from this direct ophthalmoscope. Okay, so actually how you do it, can you see? So I am just holding this direct ophthalmoscope with my right hand, and then if this is the patient, I am going and seeing the right eye of the patient with the right hand. Okay, so from my right eye where I have put the direct ophthalmoscope, I am seeing the right eye of the patient. Is it clear? Okay, I would just show you a video for that. Can you see? So first I am at 23 centimeter. I am doing a distant direct ophthalmoscopy. From that I am coming close to the patient. See it once again. So see, with the right hand I am basically holding the ophthalmoscope in front of my right eye and seeing the right eye of the patient. First at a distance of 23 centimeter, and then I am going very near to the patient. So I would like to tell you that in the COVID era, we have basically decreased this use of direct ophthalmoscope because we are going very close to the patient. So what we are doing right now is a slit lamp 90D examination. Okay, but remember, a direct ophthalmoscope, the learning curve is much lesser than a slit lamp 90D examination, and that too at least in those patients who are having a myotic pupil or a non-dilating pupil. So what are the various questions they can ask from this? The image formed, let's say I am seeing from my right eye towards the right eye of the patient. So the image that is formed of the optic nerve, that is virtual and erect. Okay, very remember, you can just remember it with the mnemonic Dev. Okay, I write it here. So you can just remember the mnemonic Dev. So in a direct ophthalmoscope, you would get a erect image as well as virtual image. Okay, and one thing that is the most important is that this direct ophthalmoscope I use to see the optic nerve head. I also call it optic disc as well as macula. But the problem here is that this direct ophthalmoscope does not give me a depth perception. What I call depth perception in ophthalmology, I call it stereopsis. Have you ever heard the name? Just give me a thumbs up. So there is normally no stereopsis when we are doing a direct ophthalmoscopy. But the advantages is that we are having a good magnification, around 15 times magnification. Another disadvantage that is there with the direct ophthalmoscope is I cannot see if there is a hazy media. So if there is a lot of vitreous inflammation, I call it vitritis, or if there is a small amount of corneal opacity in front of me, or if there is a nuclear sclerosis grade 3 or grade 4, that is the advanced cataract. So in that cases, I would not be able to see the optic nerve and macula. So another disadvantage is I cannot see through the hazy media. Okay. Last but not the least, sometimes they ask how much is the field of view that you see. So remember, it is around 10-degree field of view that we see in a direct ophthalmoscope. Okay. So these are few important points that you have to learn regarding the direct ophthalmoscope. I revise you it once again. So the image formed is virtual and erect. Remember the mnemonic Dev: direct, erect, virtual. And why we use it? We use it to basically see the optic nerve head and macula. Okay, so it is used to mainly see the disc and the macula. The problem with this is that you are not able to see the depth perception, so there is no stereopsis. Then what is the advantage? You get a very high magnification, much more than another modality that we would discuss today, that is the indirect ophthalmoscopy. So how much is the normal magnification you get? Around 15 times. Another disadvantage is that you cannot see through a vitritis, or you cannot see if there is a something which is an advanced cataract or a corneal opacity. So it cannot see through a hazy media where we use indirect ophthalmoscopy. And last but not the least, how much degree of view we see around 10 degree of view, and 10 degree of view is basically called 2 disc diopter of the field. Okay, so it sees around 2 disc diopter of the retina, which is around 10 degree field of view. Is it clear, all of you? Okay, now what are the various ways through which you can use a direct ophthalmoscope? First is, let's say this is the patient. So if you can appreciate, this is my direct ophthalmoscope. Can you see the light which is coming? Okay, so my patient who is around 23 centimeter from me, I put the light. Can you see the yellow light? I put the light towards the patient. Okay, and I see if there is any opacity which is seen there as a black shadow in the background of a red fundus reflex. Are you getting my point? So the reflex that I see from the retina, or I would say which I see from the choroid, is a red reflex. If we have any opacity in front of the lens or in the cornea, we would see it as a black shadow. So this distinct direct ophthalmoscopy can basically help me in telling whether this opacity, it is anterior or it is posterior to the nodal point of the eye. So just understand like this. If this is my lens and this is the nodal point of my lens, okay, the center of the lens, if we have a opacity which is in front of it, or if there is a opacity which is in back of it, okay, either anterior or posterior, this can be told by my this investigation, which is at 23 centimeter from the lens, which is called distant direct ophthalmoscopy. So if I move my direct ophthalmoscope, see, I am moving right, I am moving left. So if I move my ophthalmoscope right and left, and this opacity is also moving right and left, this basically tells that the patient is having a anterior opacity. But if when I'm moving the direct ophthalmoscope to the right, but the opacity is moving left, this means it is posterior to the nodal point. So this is a posterior subcapsular opacity. Okay, so this is the basic advantage of using a distant direct ophthalmoscopy. Are you able to get this point? Okay, now if you can appreciate here in this, if you can see, so just I do it more in front of you. Can you see this? These apertures here. So these apertures, if you can see, there is 5 or 6 apertures here. Okay, there are 5 or 6 apertures here, and these apertures basically have different functions when we are doing a direct ophthalmoscopy, or we are doing, if you can see here, I am just making it like this. So can you see the check? These apertures here. Okay, this is one aperture here and one here. Okay, not very clear, but you can see some marks here. Okay, so actually they are having like this. So I just make a diagram. So there is a large circle, a small circle, a half circle, a red free image, a blue aperture, or a streak. Okay, so there are few types of apertures. Aperture means few types of holes in the direct ophthalmoscope through which I can basically change the shape of the light which is going towards the retina. So what is the basic purpose of having so many apertures? So first is the small spot. The small spot basically tells us that it is basically giving us a 5 degree of view. What is the normal degree of view that we get in a patient where we are doing a direct ophthalmoscopy? I told you we get around 10 degree of view. So this small spot gives a 5 degree of view. So those patients who are having a myotic pupil, myotic means small pupil, or if there are lot of corneal reflexes that are coming like Purkinje images and they are basically avoiding a good view of your retina, you can use this small spot. Then the large spot is that I told is a conventional opening where you get around 10 degree of field. Then there is a hemi spot. So hemi spot is like this one, like this. So hemi spot also basically helps in the same way like a small spot. So it reduces the corneal reflex and the depth perception is better in a hemi spot than in a large spot. Then we have a slit. So slit is like this. So this slit basically I use whenever I have to see a depth of the lesion. Also this can be used to see the anterior chamber depth. Remember, where my anterior chamber depth is having a major role, it is having a major role whenever we have to basically see a patient is suffering from angle closure glaucoma or open angle glaucoma. One more question they can ask you in this in your viva: what is the grading of the anterior chamber depth? So remember, if they ask the grading of the anterior chamber depth, remember a grading which is called Van Herrick's grading. Okay, important question for you. Okay, then we have a blue spot here. Blue spot that we use whenever we have a corneal abrasion, a epithelial defect or scarring. So what I do is I basically stain the eye with a sodium fluorescein stain, and then I use a cobalt blue spot. So I get a fluorescent color. So fluorescent color I get whenever there is a epithelial defect or a corneal abrasion. So even if you are not having a slit lamp, with this direct ophthalmoscope you can basically tell if there is a epithelial defect or not. Last but not the least, there is a fixation star. So it is like this. I'm making a small diagram. Okay, we have a fixation star like this. So what we tell the patient? We tell the patient to look at the center of the scar. Okay, we tell the patient to see at the center of the star. If he is able to see at the center of the star, this means the patient has a good fixation. If he is basically seeing not at the center but to the side, this means he may be having a eccentric fixation. Very important when the patient is having a squint. Okay, then we have a red free filter. So if you can see here, I'm just making a light for you. Can you see this red light? Sorry, a green light. Okay, so basically what we are using a red free filter. This red free filter we use whenever we have to see a hemorrhage, okay, a bleeding in the retina, or if we have a defect in the retinal nerve fiber layer. Remember, sometimes the optic nerve head seems to be fine, but the patient still has glaucoma. Why this happens? Because of the decrease in the retinal nerve fiber layer or any defect in the retinal nerve fiber layer. So that is basically advantage of a red free filter whenever we have a patient of early glaucoma. Is it clear, everyone? Okay. Now the next question is one of the practice question for you that can be asked in your exam. The area of retina not seen by direct ophthalmoscopy is optic nerve head, macula, fovea, or ora serrata. Try to answer. So very good. The area of retina which is not seen by the direct ophthalmoscope is the peripheral retina. That is the ora serrata. So what is the instrument that we use whenever we have a patient where the lesion is expected at the region of ora serrata? We use indirect ophthalmoscopy. Okay, so I would just show you a picture of how the indirect ophthalmoscopy is done. So remember, both the direct and the indirect ophthalmoscopy, they are the dark room procedures, but I have done it in the bright room just to take the video. If they ask, your examiner asks, tell slit lamp examination, any type of laser, gonioscopy, applanation tonometry, indirect ophthalmoscopy, these all has to be done in a dark room. Okay, so just see if you can appreciate. This is my indirect ophthalmoscope and I am using a condensing lens. Can you see a condensing lens in my hand? So this condensing lens I am using to see the retina of the patient. Okay, I am just showing you it once again. So this, they can ask you what is the procedure that is going on. This procedure which is going on in this patient, this is a indirect ophthalmoscopy. Now what is the basic advantage and the disadvantage of indirect ophthalmoscopy? Can anyone of you tell? Just tell me in the comment section. So we have a smaller, a cheaper direct ophthalmoscope with us. So why I need a indirect ophthalmoscopy, which is basically having more learning curve than a direct ophthalmoscopy? The basic feature why I use indirect ophthalmoscopy is, as I told you in the last question, that the indirect ophthalmoscopy is used to see the peripheral retina. Also, in the cases where I cannot use a direct ophthalmoscopy, where there is a hazy media, I can use an indirect ophthalmoscopy there also. This condensing lens which I use, can you see here? This condensing lens that I use, that is a convex lens which can be a 20 diopter, 28 diopter or a 30 diopter like this. Okay, this condensing lens which I use, this basically is making the different amount of magnification. Okay, a 20 diopter magnification would be different from a 28 diopter. Why I use it? Basically, I want to condense the light and I want to see the peripheral retina. So a patient who is basically having a peripheral retinal lesion, like a patient who is having a lattice degeneration, or if a patient is having a retinopathy of prematurity, in that cases, or even those patients who are having a vitreous haze, this instrument is one of the best instrument for me. But unfortunately, the amount of magnification that I see with my this ophthalmoscope is much less as compared to direct ophthalmoscope. So around 3 to 4 times is the maximum magnification that I get in an indirect ophthalmoscope. So in the cases where I have to see the optic nerve and macula and the details of these lesions, the direct ophthalmoscope is much useful for me as compared to my indirect ophthalmoscope. Okay, so I just put it like this. The image that is formed is real and inverted. Remember, in a direct ophthalmoscope, it is virtual and erect. And the main advantage is it is used to see the peripheral retina and through the hazy media. It uses a condensing lens of 28 to 20 diopter, through which the amount of magnification is dependent. So my last question for you is magnification of indirect ophthalmoscope by using a condensing lens of 20 diopter is 2 times, 3 times, 4 times or 6 times. Try to answer in the comment section. So the answer here is 60. That is the refractive power of the eye, around 58 to 60 diopter. We take 60 diopter for the benefit of calculation, divided by the power of condensing lens, that is the 20 diopter. So that basically equates 3 times. So the magnification is 3 times, and this is my previous year question. Okay, so this is the most important point of indirect ophthalmoscopy. So hope this small session would have been useful for you. If you like the session, you can just subscribe for the Let's Crack NEET PG channel. I would be coming back with lot of videos, small crisp sessions for you in the Unacademy app as well as in our YouTube channel. So hit the bell icon for the notifications. Till then, it is good night from my side and Jai Hind.